Hi, my name is Rebecca and I'll be presenting to you my master's research, which was a systematic review into the effectiveness of exposure therapies for the treatment of anorexia nervosa. Fear of weight gain is central to anorexia nervosa, and when this fear is triggered, anxiety has been found to peak in patients, and this peak in anxiety can significantly predict the use of avoidant, safety and compulsive behaviours, which temporarily decrease the anxiety, and then the pattern repeats itself. The repetition of behaviours via negative reinforcement is part of Maura's two-factor theory to explain the formation and maintenance of anxiety disorders, and has also been applied to the formation of the central fear in anorexia. We also know from the formulations of anxiety disorders that negatively reinforced behaviours maintain the pathology by preserving the central fear. We know from anorexia research that the central fear of weight gain is being preserved in patients even once they've been considered as recovered, and which leads to the continuation of these negatively reinforced behaviours well into recovery. This suggests that an intervention which directly addresses anxiety may be beneficial for the treatment of anorexia as well. Currently, the primary intervention used for anxiety disorders is exposure therapy, and so we therefore aimed to gather and evaluate evidence which investigated the use of exposure in the treatment of anorexia nervosa in order to answer the question of whether these therapies would be an effective treatment. First of all, for our method, we set our eligibility criteria and used PsycInfo and Medline for our database searches. Titles and abstracts from the obtained studies were screened and eligible texts were then read in full. To extract data from full text, data extraction forms were created, trialled and amended. And for risk of bias, we used the NICE appraisal checklist for randomised controlled trials and non-randomised trials, and we used the NIH case series toolkit to assess case series. We then qualitatively synthesised the data by grouping together the method of exposure that they used. In regards to our results, 30 studies were obtained and after deduplication was done, and then 10 texts were deemed eligible. 4 studies looked at exposure and response prevention and found a reduction in anxiety and food avoidance after ERP. Caloric intake was significantly associated with food-related anxiety, and those receiving ERP consumed significantly more calories after treatment compared to those receiving CRT whose calories declined. In regards to graded exposure, 2 RCTs looked into this and found little difference between exposure, a cognitive therapy and a control intervention, and the other study found that trained relaxation was superior to the exposure intervention. One non-randomised control trial looked at a mirror exposure and found that it reduced body dissatisfaction in patients. 2 RCTs looked at DCS facilitated exposure, and one who used 50 milligrams found little differences between placebo and the DCS group, but found improved caloric consumption as a result of the exposure regardless of group, whereas those who looked at the 250 milligrams of DCS found that patients in that group gained significantly more weight. And then one case series looked at implosive therapy facilitated by aversion techniques and concluded that it was unsuccessful. There are several points that need to be considered and are up for discussion regarding each type of exposure that was studied in our review, in regards to how those studies were conducted and what the results imply. But unfortunately, the extent of which we can make confident conclusions and implications from the results that we obtained are limited because the amount of research that we obtained was small and the quality of the studies was fairly low, as we can see from the table on this slide. As a result of the low amount of research that is currently on this topic, we also had to reduce how specific our eligibility criteria was, which led to a lot of diversity across studies, limiting the amount of conclusions that we could make from the data as a collective. And it also highlights the need for future research to be on this topic to really focus on being higher quality, particularly using RCTs. And it may also be interesting for future research to consider the use of imaginal exposure in the fears of anorexia that may extend beyond weight gain, and when in a treatment course exposure would be the most effective. The results do have some implications in that it contributes to the argument that anxiety plays a key role in anorexia nervosa pathology, and it also highlights the clinical importance of assessing the role that anxiety may be playing in a patient's presentation and addressing any negatively reinforced behaviours. But overall, despite some of the flaws and the limitations that we had, it still does highlight the potential of exposure therapies in improving treatment outcomes in anorexia nervosa.